This episode of the Nurse Practitioner Podcast is sponsored by Lippincott Clinical Pulse, the next generation of audio CME learning from the leading medical publisher you know and trust as a nurse practitioner. When keeping pulse on the latest medical advances is a priority, but time is limited, Lippincott Clinical Pulse is your best option for quality podcast-style audio learning. Lippincott Clinical Pulse brings you weekly peer-reviewed content from New England Journal of Medicine Journal Watch and access to leading lectures from top institutions like Johns Hopkins and Mayo Clinic. Your membership access includes CME Credit Tracker, giving you the ability to seamlessly track the CME you've earned along the way. And for a limited time, save $100 on your one-year Lippincott Clinical Pulse membership. Start the year off right and get a jumpstart on your one-year Lippincott Clinical Pulse membership. Now is the time to get access so that you can conveniently start completing your CME. Visit clinicalpulse.lww.com to get your membership now. In this episode of the Nurse Practitioner Podcast, Victor Czerkasij discusses the golden age of dermatology. Victor, thanks for taking the time to join us today.
Thank you. Always a pleasure to be with you.
It's been a while since we've heard from you, and we're glad you're back. Tell me a little bit about your title today, The Golden Age of Dermatology. What do you mean by that?
Yes, it's the golden age of dermatology. Who realized that I could live long enough to move from one age to another, literally like the Stone Age into the industrial one when it comes with dermatology and healthcare at large. If you're new to the field in dermatology, there are probably three major happenings that are occurring, maybe without you even noticing. First is we now have multiple options of treatment for many conditions that are light years different from even 10 years ago. So if you're like about 30, 35 years old, you came out of school just about the time when we were seeing different mechanism of action and routes for conditions. And whereas we only had maybe one treatment in our armamentarium and probably 5 things that were off label, now we have things that are so FDA approved and many, many on the horizon. The second change that I'm seeing just in the last few years, as I mentioned, is we have so many options for conditions and diseases that were not available before. And of course, we'll mention them in our podcast today. And thirdly, it's the safety. So this one is kind of an interest to me because I have people that are a little nervous about the side effect profile of medications that are coming out. And I'll say, like, what's on your mind? What's on your heart? And they're like, well, if you read here, there'll be maybe possible nausea, vomiting, diarrhea in 1 out of 100 patients. And some people have postnasal drip as a side effect, and others have headache and fatigue the day after. And I say, really? Well, when I was doing this 20 years ago, it was death as the side effect. How about that? How about lymphoma? How about cardiac arrhythmia? So putting it all into perspective, postnasal drip against death, I'll take a runny nose anytime rather than a lily on my breast. So we do have a really, really different thing. In fact, take some time as a provider while you're listening and go to fda.gov, fda.gov, and check out their tab for novel drug approvals for just 2022. And it'll go back years. It'll blow your mind. I mean, I was just checking it out recently, and we had treatments I wasn't even aware of in metastatic melanoma and uveal melanoma. So, yeah, it is the golden age of dermatology, and I'm happy to talk about some of the more details coming up.
Thanks for sharing those insights on how dermatology has progressed. In your opinion, what would you consider the most dramatic news or advances in dermatology as of late? What would you say has given you the most excitement or relief?
Well, anyone who knows me and you ask about excitement, I may not need just a half hour, but maybe a lot longer. But I'll move this part along, my friends. And let's just remind ourselves what specialty I represent. Dermatology, right? It's the only major organ on display to the public. So, it's very stressful for the patient when something goes wrong. Like a change from the normal color or multiple colors on the skin, not representing something more smooth, loss of hair, right? Open wounds, places that itch and you've been scratching for a long time and they become infected and the like. So let me go through the most dramatic news or advances, as you mentioned, in dermatology going on right now. Let me give you one right now. Number one, vitiligo. So vitiligo is an autoimmune disorder which affects the melanocytes of our skin, of any background skin color, whether it's black, Hispanic, Asian, Caucasian, and of course, the darker the skin for you as your race, then you're going to really see the transition be more vivid. So we finally have just a year ago an FDA-approved topical cream called Opzelura. It's also called ruxolitinib. And I'll say on the outset that I do work for a few of the companies in discussion today. I received no kickback or any monies or compensation for being on today, nor promoting these products. I'm just talking about what I know, which is the latest medications. But what happened was Opzelura came out and is very effective for atopic dermatitis, right? Because we can't keep using steroid cream on skin because it'll thin the area, cause atrophy, and make it, itchier, believe it or not. Well, Opzelura or ruxolitinib came out, and it's for 12 and older, and it's awesome for atopic dermatitis. But lo and behold, they went ahead and got approval from the FDA for vitiligo. And that has been really dramatic. This was just a few weeks ago. So vitiligo affects Americans like what, 2.5 million in the United States, I think. And it comes in a 60-gram tube. You can use it every day, this cream, on affected areas. Works very, very well on the head and neck. And while it has a boxed warning, I explained to people the FDA put that there because it's based on a JAK technology, JAK or Janus kinase. These are comes from the god Janus. Have you remember that, the two-faced god Janus? Well, these are channels that have two sides to them, and we also get the month January from the god Janus because out with the old, in with the new. That's kind of cool, right? For your question on what's new in the golden age of dermatology. But this old technology, they gave them the boxed warning, was based on the oral medicine. So right now it's for 12 and older. You don't have to have any testing for this medication prior to using it. No labs of any kind. And I've seen the research that shows people respond in 2 to 3 months. Side effects, yeah, itching a little bit and acne, if you can believe such a thing. But we can treat acne quite easily. So that's vitiligo, FDA-approved topical cream, both for eczema and vitiligo, same cream. Let me tell you about another one, alopecia areata, right? Severe AA. When in the world did we have anything except injectable steroid in the scalp for these disfiguring, patchy, form a loss of hair on the scalp? And well, we just came out a few months ago with what's called Illumient. Illumient is a product, or called ritlecitinib, I'm sorry, ritlecitinib is another one that Pfizer has come out. It's an oral alopecia, just like Eli Lilly's product Illumient. It comes in 1, 2, 4 milligrams, 1, 2, and 4. I've been using only 1 milligram once daily. We're seeing about 80% improvement in just a few months, 3 months. Labs are required with a TB test, and you can retest if you want 3 to 6 months later. And pretty exciting. Yeah, it does have some side effects if they happen at all. They tend to be nausea, vomiting, and diarrhea, which are very common. And go through the product inserts on all of these to get more detail. And so, alopecia areata is quite a condition that has been out there and alone. We call it an orphan disease. By the way, kind of interesting background. Pfizer is in their phase 3 trials for their product for oral JAK3 inhibitor for alopecia areata. And weirdly, Pfizer was a sponsor at the Oscars this past time. And there's a huge dermatology conspiracy story, which can make it all interesting for everyone. As everyone knows, Will Smith came up and smacked Chris Rock for pointing out Jada's alopecia. There was a joke about that, right? So a lot of us in dermatology are like, weird. Pfizer becomes a sponsor for the Oscars. Weird. They got a new product on the way for alopecia. Weird. Was this a marketing ploy between the comedians? A coincidence? Yeah, it doesn't mean it was a connection, but gosh, what a story that was for those of us in the know in dermatology. So that was fun. Let me go to the third big deal happening, and that is called roflumilast, and we call it Zariva, right? So roflumilast or Zariva is a 0.3% PDE4 cream. Where do you folks remember PDE4? Anyone out there? PDE4 is oral Otezla for psoriasis. Well, now we have a topical 0.3 cream for plaque psoriasis for 12 and older. Why is that a big deal? I'll tell you. It's big because we could never use an effective cream on the face, in the groin, in the armpits, under the breasts, on the eyelids. It was always steroid. You can thin the skin. Now we have a topical that's been proven very, very safe and non-steroidal. Well, not to be undone, another company called, oh gosh, forgot the name. I do a lot of this right off the cuff, but the product is called Vitama. So VTAMA, also known as tapinarof. Tapinarof, it's a cream, 1%. It's an argyle. Can you believe this? Hydration receptor agonist. What does that mean? I'm still trying to figure that out myself. But what they've found out is in psoriasis, there is a particular receptor which is overactive in psoriasis. And this cream, this tapinarof, or Vitama cream tends to really calm it down. And again, 12 and older, very effective. Interesting thing in the trials for Vitama was that once you used it and got control of your psoriasis, it could be 200 days before the psoriasis plaque came back there. I mean, think of that. That's crazy. 200 days. That's like 2/3 of the year. So yeah, gosh, that's pretty darn exciting. We also have a new scabies treatment coming out in 2023, and I'll just kind of let all of you think about that. Here's another explosion of things in atopic dermatitis. This would be like number 6 in my points of excitement. And atopic dermatitis, we only had steroids, cyclosporin. Some of us were using Dapsone off-label. We were desperate for something. Methotrexate, for example, severe immunosuppressants, right? If you didn't get super sick and you survived, then you would have some relief from your condition. Well, oh my goodness, we have just in the last month, lots of things coming on board. We have deucravacitinib by Bristol Myers Squibb. It's called Sotyktu, also Sotyktu, and just came out last month. It's an oral for atopic dermatitis, and they're pretty excited about what they have. And then we have Dupixent, which has been around now for about 6 years. It's a subcutaneous injection, and that is been just approved in the last few weeks for prurigo nodularis, which we never had anything for PN, nothing, where you have these sores that come up on the body and very unpleasant. We also have oral Rinvoq, UPA, we call it, upadacitinib. I don't know who's in charge of these names, but the reason for the names is because it's a map. When you read the name, then you know the function. There's Rinvoq, which is an oral tablet. It's much more effective in the trials and head-to-head against Dupixent also, but it requires labs. There's Sabinco, that's a tablet for atopic dermatitis. And then there's Adbry, which is an injection. So, I mean, the list just keeps going on about what we have in the last 6 months to a year, if not a few weeks ago. I might also continue with Berdzheimer gel, 10.3%. What is that? What is Berdzheimer gel 10.3%? Well, now that I got your attention, it's going to be hopefully going into phase 3 trials in FDA-approved therapy for molluscum contagiosum. Everything we have for molluscum is off-label. So, this is going to be great, and hopefully we'll have at the end of 2023, that's what's going to be available to us.
We appreciate your insights on those drug updates. What do you attribute or account for all of these improvements and advances?
Well, right now I'm going to disappoint all the Star Trek fans. I happen to be a big Star Trek fan, but I think a better illustration to answer your question would be Luke Skywalker. He's riding his X-Wing fighter. Remember the first Star Wars when it came out in 1977? I was in high school. I was 17, and we had never seen anything like it. And of course, he rides his X-Wing fighter against the Death Star, and he drops his photon missile in the trench, and down the shaft it goes, and everybody has to pull away, and that thing blows to smithereens. Now, what in the world does that have to do with your question? It's targeting. That's what I attribute or account for all these improvements and advances is targeting. We have medications now that are not a shotgun approach where, they shoot the pellets all over the place and are scattered. It's a single focused attack on what's wrong. So we know what we're doing in healthcare, or I should say in bioengineering and research, is we're doing reverse engineering, right? We find out what's the problem, what's causing it. Well, we go backwards and then we say, okay, at what point can we use a medication to stop this process, right? So these medications today are thanks to advances in molecular and genetic studies that they have fine-tuned and learned to understand the inflammatory response and the proteins and the regulatory channels and the feedback loops. So what we're able to do at certain points is use these medicines to disrupt a spot and not necessarily turn it off completely, because there's a purpose for all of our inflammatory responses. We just want to kind of calm it down. And I have people say that to me like, oh, I heard this medication's an immunosuppressant. I don't want to take that. And I go, oh, yes, you do, because your immune system is on fire. I mean, it is really moving along here and causing a lot of disruption in your life, and particularly in your skin. Let's bring you down from 175 miles an hour into a safe car going 65 miles an hour with the rest of traffic. Otherwise, you're going to be in trouble. So to answer that is these improvements and advances are thanks to better targeting, aka Luke Skywalker and the Death Star.
Better targeting via reverse engineering looks to be paying off incredibly well. Is there anything new for antibiotics? I understand that diseases and bacteria continue to make headway. Is science keeping up?
Fortunately, in dermatology, we have some really good options for treating these bacterial infections when they come up. I'm a big believer in culture and sensitivities. You take the Q-tip out and you touch the wound where there's some exudate, some serous sanguinis fluid. You pop that into the gel in the bottom of a test tube and send it to the lab. And what they'll do is they'll tell you what is the bug and what is the drug that you should use, right? The right drug for the right bug, so that we don't waste time with not healing someone up and also inducing resistance. Just don't want to give things willy-nilly. So yeah, we're really fortunate that we have two that I just wanted to briefly touch on. And by the way, remember the skin is a kind of an interplay between the inside of the body and the environment, right? So the inside and outside is where we have the skin, and that's where the bacteria, the biome is always at battle. What's working good for the body and what is dangerous to the body. So the first thing I'll mention is called sarecycline. Also, the brand name is called Sacera. That came out in late 2018, and it was kind of pre-pandemic, and the company did not really market it very well. And then the pandemic happened, and of course everybody kind of shut down. I never closed. I never lost a day of work because of COVID. We stayed our office open the whole time. We're in healthcare, and we felt that was our responsibility to be accountable to our community and be there for them. So sarecycline we started to use, and we like it because it's for moderate to severe acne alone. And it's the only antibiotic that we have for that. And I was wrong when I said that it was 2018. I apologize. I was confusing it with another one. But the point is, sarecycline did come out just about when the pandemic was going on, and didn't get a lot of exposure. But it's interesting because it's the only antibiotic we have specifically for acne. It's for 9 and older. It's weight-based dosing, and you can take it with or without food. And, it's only for 12 weeks. So that's kind of neat, and certainly it's not for people who are allergic to the cyclins. The family is really expanded. Let's go through that. It's tetracycline, right? Then doxycycline, which is huge, minocycline, and now we of course have the sarecycline. So yeah, that family is really growing. Then there's another one. It's called omadacycline. Yes, it's true. It just it just continues to expand. They call it Nzira, and this is a broad spectrum gram-positive, gram-negative antibiotic. They're the ones that also were pre-pandemic and not getting the bang for the buck for the healthcare workers to know about, but it's extremely effective against pneumonia, MRSA, strep, E. coli, Enterococcus faecalis. Their Clostridium difficile cases were almost none. Adjustments in renal and hepatic, didn't have to worry about them. It also comes in a weird kind of a loading dose of 3 tablets, making 450 milligrams. And then you take, uh, let's see, I think it was, yeah, you take a loading dose of 450 milligrams, I remember, for the first 2 days, and then you go 300 milligrams every day for about 7 to 14 days, depending on your experience as a provider and how bad the patient is. So, here in the South, where I am in Tennessee, MRSA is worse here than anywhere else. It makes up 66.3% of infections. The lowest rate is up in Maine and the Rocky Mountains. So I'm glad for products like this to be of assistance to us.
Thanks for those antibiotic updates. Why are some of the medications oral, some topical, and others injectable? What's the decision making behind these innovations?
One of the big drivers of how to make a medication the way it is, whether it's a cream or oral, certainly injectable, is going to be mechanism of action. So that tells us how the medication best works. Why, for example, picking on Dupixent, is that an injectable? Wouldn't it be great for atopic dermatitis, and the medication's approved down to 6 months old? Do you really want to give a 6-month-old an injection once a month for their eczema? Well, we actually do, because some of those kids suffer so badly, and while they may not be happy about it, they do so well, and it's been so safe. But the reason it's an injectable is because of mechanism of action. We have to bypass the tummy, the gastric enzymes, and so that's why it's an injection. So that answers that. Another thing is patient compliance, right? If you're more likely to do something when you're happy with it, patient preference. Like, my favorite food is Indian food. I don't know why my wife even asks me, like, you want to go out to eat? Where do you want to go? And I'm like, oh, well, I prefer Indian food, so I'm most likely to do that. Second favorite is Thai food, right? Can't go wrong with that. So when a person is compliant, they're more likely to be happy with their medication. So that's why they're coming up with more effective routes like a cream or a lotion or tablets. And that moves us to the third thing after patient compliance and preference, mechanism of action. The third area to answer is what's behind the decision making on these innovations is effectiveness and side effect profile, balance. Some of the tablets are very, very powerful acting in eczema, right? The tablets over the injections. But we now have a side effect profile awareness and lab requirement that you didn't have that with the injections. So there's a constant yin and yang. There's a constant push and pull. There's this seesaw balance that drug companies and healthcare and patients are always being quizzed on. And it's nice that we've come to a place where I can pick on psoriasis. I now have psoriasis topicals that are very, very safe. I have psoriasis injectables, very, very safe and effective. And I have now psoriasis injectables. So oral, pills, injectables, and topicals, all for one condition. So whereas, 10, 12, 15 years ago, you just had immunosuppressants and the very early biologics, which weren't effective or very good for you.
Thanks for pointing out the reasons behind those distinctions. I think I can understand why some conditions seem to have multiple new developments, as they frustrate more people and are more likely to help people. But they also make more money for drug companies. What hope does that leave for the so-called orphan conditions? Do these conditions get left by the wayside?
So believe me, the conditions are not being ignored because of lack of investment by venture capitalists or I know how drug companies work to a certain extent because I sit on so many advisory councils to give them, better direction what to do. And there's a famous story of me, kind of as a side note, where a few years ago there was a major company that said, "Hey, we're going to have this approved by the FDA in a month," and I was like, "No, you won't. And here's why. And this is what you should change around." They didn't believe me. They said, "Look, we're a multi-billion-dollar company. I think that one guy sitting in a chair in Tennessee is not going to be really that accurate." And lo and behold, it took another year and a half for them to work that out just where I pointed it out. So, sitting on an advisory council really gives us an idea of what's happening as an interface from healthcare to the companies themselves. They need that direction. As a result, to this day, they are fairly appreciative of what I had to say. Anyway, let me give you some examples. I just don't think they're being ignored because of lack of money. It's just that they're that tough. I'll give you one. Skin tags. Now, you're going to laugh, right? Skin tags. Does anyone ever died from a skin tag? Has anyone gotten an infection from a skin tag that took them to the emergency room? I guess if maybe they used an electric arc welder maybe for their neck. But seriously, skin tags in the armpits, the neck, under the breast, in the groin area, they're annoying. They're in sensitive areas. Why don't we have anything? Well, we don't. There's just been nothing super effective for that. The FDA just sent letters to Amazon for Amazon to knock it off when it came to people trying to sell things as cures for skin tags. It's just not there. Here's another one, sweating, right? We have only like one product for hyperhidrosis, and it's very frustrating, and there's not much movement in that area. I'll give you a third. How about warts? Yeah, every person listening right now to this podcast who's in healthcare, it's so simple and yet so frustrating. Imagine like a 12-year-old comes in with warts under the fingernails. You know what people do? They send them to me in dermatology as a doctor referral. And I'm going to find you folks and I'm going to hunt you down one day. And I'm going to have a stern talking to you because I can't send them on anywhere else. It's the end of the line. I get it. It's not easy. What do I have for warts under the fingernails or, the kid that doesn't like injections? We just do our very best. I don't have a pill. I don't have a cream. I don't have an injection, that you give in the arm. It has to be straight into the wart itself. How about general hair thinning? So we got something for alopecia areata, but what about androgenetic alopecia, where the hair thins, and turns to balding, which is different from the areata, or universalis or totalis? Well, sure, there's oral minoxidil, there's oral spironolactone, which is a blood pressure medication. There's finasteride, known as Propecia, that is a off-label use of a prostate drug. But we're out there in the middle of nowhere, just trying our best. How about this one? My parents, 93 years old. I go see them, and they're like, "When are you guys going to come up for this bruising? This purpura." That we wake up, we don't even know how we got it. It's on our arms, our legs, and it's very frustrating. You may not even be on a blood thinning medication like aspirin or warfarin or Coumadin or Plavix, right? But you're going to have that. And so we got nothing. I'll give you one more. Seborrheic keratosis. The number one reason why an adult will come into dermatology for the first time in their life, if it's a guy, it's his wife sent him. And, the person comes in and says, "Hey, I wasn't born with this. It's popped up." And I go, "You're 35 and older." "Yeah. And it's probably where hair follicles." "Yeah. It's not on the palms of hands or soles of feet." "Yeah. But, it's on my arms. And I used to run my hands on my arms. It was smooth. And now I'm running into these speed bumps." And I go, "Well, welcome to life. You are now an adult." So I believe that priority should be on the more serious issues first, right? Like the old women and children in the lifeboat ideal. But I hope we can get to some of these others because, frankly, if someone comes up with a treatment or a cure for seborrheic keratosis, they're going to own most of Hawaii.
We appreciate you sharing those insights. Are there similar advances in other fields that you're aware of? It seems that dermatology has major changes. What do you know about other specialties?
I can tell you right now that things are happening across the board, that whether you're in cardiology, nephrology, oncology, telemedicine, thanks to the pandemic, has been a big deal. And so that continues to be of great use. People tend to be more compliant visiting with their provider if they can't come in. And so, there's also some fear and anxiety still from the pandemic. So yeah, that's something that all of us are using. Another thing is artificial intelligence. We now have these cool apps that are not quite FDA approved yet, and they're working out the bugs, but artificial intelligence where you can have an app or some equipment that reads the moles and gives you an idea of what you're looking at. 3D printed devices are something that's happening across the board. I would say that we're watching with wonder the area of biosensory and health tracking. So a person can get a pretty good idea of their cardiac rhythms on a regular basis and their blood pressure. And, that's been very, very interesting to see that. Many, just kind of an aside, many specialties are lifestyle associated. They're based on personal health choices. And that affects us all, whether cardiology, rheumatology, diabetes control, mental health. That's been a really big area, as I mentioned earlier, with anxiety and stress from the pandemic. Pain management. I mean, let's take a look what's happening in the country right now. Let's be honest and open. The government has very, very strongly come down on not allowing us to prescribe opioids, but people will find a way. And fentanyl has been killing 300 Americans a day. And we have a lot of it. And some of it is laced in a dangerous manner. And people will find a way for their pain. Vascular, that's a huge issue where a lot of specialties are focusing more on lifestyle. And we have major changes, but we're all coming to an idea that we need to live healthier so that we don't get sick. I think a really good life insurance policy is good health. Right? That's what you should focus on for all of us, and eating better. I just finished a study where we found the Mediterranean diet combined with medication is extremely effective for decreasing pain and the effects of psoriatic arthritis. So that was shown to be statistically significant. By the way, I would encourage anyone listening that anytime, no matter what specialty you're in, all right, I'm just going to say this right out, whatever specialty you're in, remember your brothers and sisters in the other ones and do a referral. I think patients will appreciate that. I've had just in the last 6 months where someone said, it really itches and burns around my nipple. And it's a guy. And I said, well, let me send you in for an ultrasound. And the first one was simple gynecomastia. Oh, okay, it's a relief. So we know it's not a dangerous condition. The second one, breast cancer. So here I am in dermatology sending people for ultrasounds, and you just never know what you're going to find. So patients appreciate that, and it'll be really good for you too.
We look forward to seeing how these advances continue to evolve and benefit patients moving forward in all healthcare specialties. What's still on the horizon for certain conditions? Are there some gaps that you're hoping for some help?
Yeah, so we know melanoma continues to be a real problematic area because, how do I say this? It takes a team of oncologists, dermatologists, people who are immune specialists to really come up with what's needed there. I find melanoma probably once every other week. Certainly I can find 25 skin cancers in a day. But melanoma is very, very deadly as well. So I'm hoping for better genetic sequencing, a better immunotherapy products. And I mentioned devices on the horizon like the SLA, the skin lesion analyzers and devices, or apps. I don't know if that's going to cut out pathology. What about the false positives, or how about false negatives, right? What's the training, the safety? What's the standards for that? So, I mean, that would be really, really helpful. I think also there's a phase 2 trial going on for cutaneous lupus erythematosus. It affects women predominantly and Black women the most, 10 times more than the average person with a CLE in the population. So that's going to be really, really good. It's a subcutaneous injection. I hope that the biosimilars coming out that are supposed to make things cheaper will also be within FDA standards for safety. And that, again, doesn't really answer the question on certain conditions. But I did mention earlier, there's a lot of benign things that if they can come up with for warts or seborrheic keratosis or skin tags, that's going to be a huge part of the population complaint every day.
All right, we're looking forward to these additional advances as well. Is there any bad news among the good news?
I'm pretty cheerful with what's been happening in healthcare. After all, this is entitled our podcast today, The Golden Age. I mean, who am I to complain? Good grief. This is a really, really good time because I have the perspective of the past and today. So we are inundated lately with a lot of monkeypox warnings. So that's kind of the bad news among the good news, which is not monkeypox itself. It's just that we're constantly having to kind of screech the car to a halt and say, "Wait, what? I was on the highway doing so well, and now, we're coming out of the pandemic and you're wanting me to look out for monkeypox." Well, what does it look like? Well, they tell you. They say it looks like insect bites or shingles or even herpes. And you stop for a moment and say, well, wait, I have people with insect bites every day. So, the bad news among the good news is new things keep coming up and popping up out of left field, so to speak, that you never expected. One more thing I might mention in the things that are bad news among the good news, or things that kind of still make me pause, and I think anyone in healthcare listening will agree with me, right? So I'm giving you new medications on safety. All right, yay, they're really, really good. Number two, efficacy. They really, really work. Oh, wow, okay. And guess what? Number three, they last a long time. I mean, once you start using the medication and you maintain it, it just has a beautiful line of durability, right? Safety, efficacy, durability. But what's the problem that's bothering me? Well, all the drugs that I mentioned today, access. No, insurance companies are not happy to cover these. They're new. They feel that maybe there's other combinations you can go back to. They send you the prior authorization forms that can take a lot of time and effort. So I got this shiny brand new car, loaded with all these features and goodies, and you can't get in. Sorry, you can't afford it. You will never be able to drive this. Good luck to you. So, I'm being facetious there, but certainly access is something that we all need to come up to better way with. How do I get my patients to do it? I have a biologic coordinator. We work with each other every day to write the letters appealing to the insurance companies, explaining why this medication needs to be given. We don't have anything else. We don't want to use off-label products. This one is much safer, or they've failed a number of times. And that's always sad. Insurance companies make you go through what I call the walk of shame. Okay, you're going to fail on this and fail on that. And after you're really feeling like a failure, maybe we'll give you something good. But that's the system we have at the moment, and it is the little bad news among the good.
You've always got to take the good with the bad, right? Do you have any final thoughts?
Yes, I do. Stay off TikTok. This is where a lot of patients will come in and tell me about what they've seen. And I just have to laugh because there's so much misinformation out there when it comes to, particularly in skin. I understand TikTok also has other crazy things that happen, like bite into a ghost pepper or something like that. So I'm just simply saying that we need to continue to, as providers, to get our information from really, really good places, and always look at the package insert of every medication. That's the Bible for the drug, and take it very, very seriously. Um, Other things, this is directed probably to the newer providers. You might be impatient and nervous with a lot of these medications that have come out, and you may look at that and say, well, maybe I will stick to something that I'm more familiar with rather than move into a new territory. I'll say this as nicely as possible because I care about you and I care a lot about your patients. Don't let your fears impede your patient's improvement. Don't let your lack of knowledge keep your clients from progressing. You have an obligation to learn about these new medications and things that are coming out on the horizon, and to be aware of them. If you're doing the same thing that you did when you graduated from school, that is just not of any help because things are moving at such a fast rate. I have always kept up, and I will be reading stacks of things, and I tuck them away, and I do talk to the drug reps, and I do go to the drug company websites. I read the package insert. I look at the research. The research is a huge area because you have to learn to read research, right? You have to understand how they came through the trials. What does it mean to be random controlled? What does it mean to be double blinded? What role does placebo hold? How does this medication at 12 weeks compare to this other one at 16 weeks? So I'm just speaking from my heart and asking you to really, really learn about these things so that you can really take care of your patients in the best possible way. One other thing I would say as a final thought is lessons from COVID. And lessons from COVID are a big thing for us here in dermatology, because here's the question: why did the inflammatory response of some people to the virus, to their immune system, allow survival, or why did some have complications leading to death? And we need to better understand the inflammatory response in the immune system so that the medications will make more sense. My parents, both 93 years old, had COVID before there was any vaccine. So it was very frightening to a lot of people, and they brushed it off. Why them and why not others? So that's a study of the immune response. So some ended up in ICU, right? I think the first person in the county that I live in that had COVID and passed away was undergoing chemotherapy for stage 4 cancer, right? So that makes sense. But conversely, why did healthy individuals also have this huge response, and it was not expected? So, we can drown in our autoimmunity and this overwhelming response to the trigger like COVID, and before COVID can get us. So these will be big studies in the future, if not right now, and they have ramifications for many of our autoimmune diseases, which we're exploring medications at this very moment that are in phase 2, 3 trials and just coming on the market. Remember, if you understand, this is the biggest lesson for you, if you understand going forward how a condition works, right? Like if you understand how psoriasis operates, right? It's the overproliferation of particular proteins or cytokines in the skin that can also be stimulated from the outside as well as the inside. If you reverse engineer it, then the medication will make more sense. And you should have a better feeling about taking care of your patients in the safest manner. I really appreciate being part of the podcast today. Looking forward to a return in the future.
Thanks for taking the time to chat with us today, Victor. It's always a pleasure. For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. If you like what you heard today, please leave us a 5-star review on iTunes, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at The Nurse Practitioner Journal, and on Twitter at TNPJ_journal. Thanks for listening. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks for listening.